Good morning all. So I'll be presenting two abstracts which were presented in the last SABCS meeting. So the first one is an update from the landmark Catherine trial. So phase 3 study of adjuvant adult trastuzumab emtansine versus trastuzumab for residual invasive HER2-positive early breast cancer after neoadjuvant chemotherapy and HER2 therapy. Catherine final IDFS and updated OS analysis. So we know the design of the Catherine trial. So patients with HER2-positive breast cancer who received prior neoadjuvant therapy, which should at least include trastuzumab as well as chemotherapy, were randomized if they had residual invasive tumor in breast or axillary nodes, and the randomization was within 12 weeks. And so they were randomized into two arms. One was the TDM1 arm, where they were given TDM1 in 14 cycles, 3.6 milligram per kilogram, and the other arm was continued on trastuzumab. The primary endpoint here was IDFS, and secondary endpoints included IDFS with the second primary non-breast cancers, DFS, OS, DRFI, safety, and QOL. And it was stratified based on all important parameters. So in the primary analysis, it was clear that there was a definitely improved IDFS in the TDM1 arm, that is 88.3 versus 77. And the OS data was immature to analyze at that point. So the timelines for the analysis were, the final analysis was scheduled 12 years after the first patient inclusion. And it was event-driven, and approximately 384 events have been recorded. And second, OS interim analysis was also pre-planned. And now the median follow-up time was 101 months, and 60 months longer than the primary analysis. And there were around 215 OS events. So coming to the numbers, 743 patients were randomized into each arm. 720 were treated in the trastuzumab and 714 in the TDM1. And currently, 62% of patients are alive in the trastuzumab arm and 70% the TDM1 arm. And discontinuation rates are 21% in the trastuzumab arm with the event reported, and 14% the TDM1 arm. And prior to IDFS event, discontinuation rates were almost similar, 16 and 15. So this is the analysis milestones. In the baseline characteristics, we all know all the parameters comparable, and majority of the patients received trastuzumab alone as the neoadjuvant treatment, and around 20% of each arm only received pertuzumab-based treatment. And other parameters, almost half of them were not positive, and 3/4 had prior anthracycline. So in the final analysis, at the end of a median follow-up of 8.4 years, the 7-year IDFS is 80.8% in the TDM1 arm versus 67% the other arm. So the absolute IDFS benefit of 13.7% at the end of 7 years. And with the unstratified hazard ratio of 0.54. And this was maintained across all the groups. I have not included those slides because I'm not going into the details, but it was significant across all subgroups. And if you look at the site of first occurrence of IDFS events, in the TDM1 arm, one interesting thing is that the CNS relapse rate was 7% the TDM1 arm versus 5.1 in the trastuzumab. All other aspects, the TDM1 group fared much better. So that is something to look upon. And as for the OS, at the OS interim analysis, median follow-up 8.4 years, 7-year OS is 89.1% versus 84.4% in the trastuzumab. Here also an absolute OS benefit of 4.7%. So HER2-positive breast cancer receiving neoadjuvant treatment, our survival rate is close to 90% at the end of 7 years with this new strategy. And coming to the deaths, cause of death was breast cancer in around 108 patients in the trastuzumab, that is 15%, and TDM1 it is only 9.5%. And the subsequent treatment, which is very important, as there are multiple agents available in HER2-positive breast cancer, you can see that 3/4 of the patients received some form of subsequent treatment, and around 40% received pertuzumab in the trastuzumab arm versus it was around 30% in the TDM1 arm. And tyrosine kinase inhibitors around 18%, and majority received trastuzumab, like that is 67% in the trastuzumab and 55% the TDM1 arm. And other chemotherapy agents are also equally used between the groups. So the taxane use is slightly higher on the trastuzumab side. And adverse events, we know the initial analysis has shown a lot of significant adverse in the TDM room like neuropathy, but over the time most of these adverse events have subsided, and it is sort of comparable, and there is no definite increase in the cardiac risk with the TDM1. So their conclusion was after 8.54 years of median follow-up, TDM1 significantly improved OS in patients with HER2-positive breast cancer with residual invasive disease with an OS rate of 89.1% versus 84.4%. 4%. And IDF's benefit was also confirmed, and that was significant across all groups. There were no new safety signals. And they conclude TDM1 is the first therapy to show improved survival post-surgery in patients with HER2-positive early breast cancer with residual invasive disease. And follow-up is ongoing with the final OS analysis. So we have discussed this trial multiple times. It has sort of become the standard. So the only concerns raised were like whether the control arm is the real standard, because now the standard of care has changed to pertuzumab in the neoadjuvant arm, and in the adjuvant setting, it is still controversial. So the role of TDM1 in relation to these factors are not very clear, and there are some concerns about the role of HER2 loss in patients receiving anti-HER2 therapy, but the last year update has shown that in this group also there is a benefit with TDM1. And the only practical issue that we face in the clinic is the financial toxicity associated with TDM1. Otherwise, as per the guidelines, this update also confirms, it gives us more confidence to use this drug in the adjuvant setting. So coming to the next abstract, that is also presented in the same conference, the HER2CLIMB-02 study. It's a primary analysis of a randomized double-blind phase 3 trial of tucatinib and trastuzumab emtansine for previously treated HER2-positive metastatic breast cancer. So we know tucatinib is a highly selective HER2-directed TK, which has shown its efficiency in CNS metastasis, especially in the HER2CLIMB study, which was published before, where it was used in combination with trastuzumab and capecitabine. And we know that CNS metastasis is a major problem in HER2-positive breast cancer. We need effective strategies to address this problem. And TDM1 has already shown its role in metastatic as well as the adjuvant setting. So based on the preclinical data and initial phase 1B about to study, a combination of tucatinib and TDM1 demonstrated encouraging anti-tumor activity, including intracranial response, with a manageable safety profile, which led the investigator to take up this phase 3 trial. So the design is patients included were HER2 positive, locally advanced or metastatic breast cancer with progression after trastuzumab and taxane in any setting, and PA 0 to 1, and previously treated stable, progressing or untreated brain metastasis not requiring immediate therapy, local therapy were included. And they were stratified based on the line of treatment, hormone receptor statins, presence of brain mets, and the performance status. And 460 patients were randomized into two arms. The experimental arm was TDM1 plus tucatinib, TDM1 in the standard dose and tucatinib 300 mg per oral BD, and TDM1 was placebo. Primary endpoint was PFS by the investigator assessment as per RECIST 1.1, and key secondary endpoints were OS, PFS, overall response rate, OS in patients with brain metastasis. So the baseline characteristics, these are all comparable. And if you look at the incidence of brain metastasis, 43%, around 45% had brain metastasis in each arm, and 20% had active brain metastasis, and 20% had treated stable brain metastasis. And initial stage of diagnosis was 0 to 3 in around half of the patients, and rest was metastatic disease. And if you look at the median prior lines of systemic therapy, like majority of the patients had at least one line of treatment, that is 64% in each arm. And the patients who received prior trastuzumab was close to 90%. So all these patients received a standard of care treatment at that point of time. And if you look at the primary endpoint, that is PFS, it was found to be superior in the experimental arm with a median PFS of 9.5 months versus 7.4 months with a hazard ratio of 0.76 and p-value of 0.0163. And in patients in brain metastasis also this outcome was maintained with a median PFS of 7.8 months versus 5.7 months, hazard ratio of 0.64. And if you look at the overall response rate, it was higher in the experimental arm with a 42% overall response rate, and around 4.3% having complete response, and it was 36% in the other arm. And overall survival, it is not time to analyze the overall survival. The median survival was not reached in the TDM1 plus tucatinib arm, whereas it was 38 months in the other arm. So coming to the adverse events, so the most common adverse events observed with the experimental arm was liver dysfunction. That was SGPT and OT was increased in around 16% in the experimental arm versus 2.6 in the other arm. And anemia, thrombocytopenia, fatigue was also higher on the experimental arm. But if you look at the SAEs, like it was 30% in the experimental arm versus 22% in the control arm. So the hepatic adverse events were one of the concerns, and it was 28% in the experimental arm, primarily due to SGPT OT elevations. But important thing is that 85% of all grade hepatic adverse events have returned to grade 1 with a median duration of 22 days. Another important toxicity was diarrhea, and more than grade 3 events reported in 4.8% of patients with TDM1 to catinib, and it was 0.9% the other arm. Now grade 4 events. So this is the dose modifications and dose reduction related to. I think the authors conclude this combination improved the PFS in patients with previously treated HER2-positive metastatic breast cancer. Median PFS was 9.5 versus 7.4, and PFS HRs for specified subgroups were consistent with that of the overall population. And brain metastasis also this combination is found to be superior. And adverse events were consistent with those previously reported. And though there were higher adverse events, all of them were reversible. So this is the second randomized study, including patients with brain metastasis, demonstrating that this combination has higher activity. So definitely, though abstract is only available, this is sort of a technically chemo-free regimen, which is effective in CNS metastasis. It's a major problem in HER2-positive breast cancer. And the subgroup is heavily pretreated, including 90% of the patients received pertuzumab. And though adverse events are there, they are all transient, so they will return to normal within a short duration. But at the same time, we need to have OS data, it's still immature. And in HER2 positive, we have multiple agents. How to sequence this, that is still a question. So where to keep it with respect to TDXT and the other previous regimen, whether it can be compared to the other regimen. Though the adverse events are reversible, we really need to see how it has affected the quality of life of these patients. So that's it. Thank you.